Am I freezing or something? Or did something happen? Toad?
I can
Hello?
hear you clearly. Okay, I have a question here. Is that
Yes,
okay?
okay. Ask question anyway.
Yes. Pertinent. It is the same meaning with appropriate. Pertinent, positive or negative.
That is like yes on that's like what related to the cheap complaints usually. So if you do a shoulder exam, you definitely list it there. But if you do a knee exam, you don't have to list it there because it may not relevant. You choose what relevant to the patient, stuff like that.
Yeah, something related to the cheap complaint.
Mm-hmm.
Okay.
Something definitely related to cheap complaints.
Yes.
That's right. All right. For some reason, we have some technical difficulty. So I will share my screen. Yeah, I think something going on with the issue with the technical stuff today, and I'm terrible at it. But I will share my screen.
Shares again. My internet so bad.
Okay, no
But
worries.
go ahead.
Does everybody see my screen? Okay, everybody see it.
Yes.
Right? It may not have animation or something, but do you see it? Okay, good.
Yes, good.
Good. Okay. Vital signs always go first. Okay. Blood pressure is 130/90, heart rate 75, respiratory rate 16, temperature 97, and 98% oxygen at room air. Okay, that's all the vital signs. It's important. Okay. You guys may use Celsius, but we use Fahrenheit over here. So 97 is about 37 degrees Celsius. So should be okay. And whatever you do in clinic as well. So what I usually do for all my diabetes patient at their visit is I tell my nurse, hey, can you do an A1C and glucose right there? So I just put it there. Okay, patient hemoglobin A1C 6.7, glucose 103 today. I just put it there because it's part of my labs. Then I do a physical exam. Again, I do a top-to-toe physical exam, but you should do the physical exam that related to the patient cheap complaint. Okay, so first you look at the patient. Is he in distress? So he is. He look like he's in pain. So you put in acute distress due to pain. Alert oriented time 3. AO time 3 usually alert and oriented time 3, which means do the patient know where they are? Do the patient know what day is today? And do the patient know why they're here for? Stuff like that. You have to ask those three. But usually if the patient, you know right away if the patient is aware, awake and alert or not. So you usually don't need to ask those questions, but you will know. So and then you do a heart and lung exam. R mean regular rate and rhythm. Regular rate and rhythm. No murmurs. No JVD. No edema. You know what JVD is? It's jugular venous distension. So you check the neck to see if there's any distension of the neck vein. This is where the jugular vein is, and if it's positive, they have some fluid issues or the right heart is not pumping well. Respiratory, you listen to the lungs, both sides. No wheezing, no rails, no crackles. Okay, good. And then you do the shoulder exam. You should do the good shoulder first. Okay. They say, oh, I'm hurt on my left side. You should check the right side first because you want to know what their normal is so you can compare. Okay, the right side have full range of motion, normal strain and muscle tone, no tenderness on palpation. Good. Then you do the special test, near test, Hawking-Kennedy test to check for shoulders, impingement, stuff like that. Nowadays, we have a very powerful tool in the office. Do you know what it is? I think Hương knows this. Do you know what is the most powerful tool that we have in clinic that we can use to assess the patient right away, and it's cheap? Okay, it's called ultrasound. Point of care ultrasound. Nowadays, they have a little butterfly thing. We call it a butterfly. Hook it up to your iPhone, and then we can use it to do ultrasound on patient. I have the app called, okay, you probably won't be able to see it, called Butterfly right there. Okay, I use my Butterfly Ultrasound Pro, and then I hook it into my phone, and then I see if there's any fluid or any inflammation under the shoulder. I do it right away with all my MSK complaint. It's fast, and it's also really fun too for the patient to see their own shoulder. We call it's really recently new developed. It's called Point of Care Ultrasound, or POCUS. If you Google this, you will see a lot of research about it. And the equipment that we use is called Butterfly Ultrasound Pro. So it's expensive though. It might not be accessible in Vietnam, but this thing is like $1,000. So it's very expensive. Our clinic have it, so I just use it. Okay? But if you have access to ultrasound in the clinic, do it, and then you note it in the objective section. Okay? Any questions so far? Tone, did you do ultrasound in the clinic a lot? Shoulder ultrasound? Or Hương, you do ultrasound?
Yes, I use ultrasound regularly. It is
Perfect.
my daily work. Yes.
So
But,
who will be an expert? You need to ask about ultrasound, okay?
Yes, but in my hospital, there is not yet butterfly US probe. We just do, the normal ultrasound machine.
So it's like the machine where you push it around, and right? There's a big one, right? Okay. We have it in the office too, but we like the butterfly better because it's small. Yeah, it's expensive though. It's very expensive, I know.
Yes. Yeah, of
I
course.
want to buy one too, but I don't have money.
Yes. Yeah, of course, I haven't heard about this before, but it's a kind of expensive. But I think it's very useful. If you have money, I think it's the better choice. It's the better choice for you to examine the patient very, objectively.
Yeah, for me, I only use it to show the patient what they look like, but I can't document it because I'm not certified to be looking at ultrasound. Okay, so in United States, you have to do at least like 50 of them under the supervision of the radiologist, or your note have to be certified by the radiologist 50 times before you can do ultrasound by yourself in clinic and tell the patient, oh, your shoulders have something wrong. Okay, usually what I do is just to let you know, this is just for educational purposes. I'm gonna take a look at your shoulder under the ultrasound, but please be mindful that whatever I say may not be true by what the radiologist say. Okay, so don't take my word as a medical advice. You always have to tell the patient that if you're not certified to do ultrasound, you can still do it. It's fun to show the patient what the shoulder look like. Most of them are surprised. Oh, that's my shoulder look like. Okay, but before that, you have to tell the patient, okay, I'm not certified to do the ultrasound, but I will show you what your shoulder look like, and please be mindful that none of this is a medical advice. It's just educational purposes. You have to say that, otherwise patient will go around and say, "Oh, my Dr. Nguyen, tell that I have a tear in my shoulder," but in fact he did not. Just I can't see it on the ultrasound, and I thought he got a tear, and I tell him that. And it's like, usually if I see something abnormal, I will tell her, "Oh, it seems like there's something going on in the shoulder. I'm not sure. So you should check with the radiologist to make sure." Stuff like that. Okay. And never say anything if you're not sure. Learn it the hard way. Like I use ultrasound on my patient heart, and it's like, it seems like you don't have the valve there. It seems like your heart valve is not working. It's like, "Oh, my heart valve is not working, really?" And then they go and tell everybody about it, and oh, that's bad. Yeah, never say anything that you're not sure. If you're certified to do it, that's perfect. You do whatever you want. If you're not, make sure you tell them it's for educational purposes. Next slide. So, what's your assessment with this patient? What do you think the patient has? Anybody know what do they have without imaging? Think about at least 3 differential. Okay, 3 differential. So what you think patient have? Now for this time, I'll make the differential for you. So usually I combine my assessment and plan together, because on my chart it's one thing. I don't know about other medical record or hospital, but usually I combine them and then I write my plan under each assessment for easier. It's easier to see, and it's easier to know what I do with each assessment. So, but you can do your way. You can write all the assessment, and then in your plan you start to write out what you do. But for me, I like to write under each assessment. So my assessment for this patient is okay. Sometimes it does not have to be a definitive diagnosis. I don't know if your hospital want the definitive diagnosis, but over here I never make any diagnosis on my patient unless I'm really sure what's going on. I just list shoulder pain as my assessment, and then I put in my differential under it. Okay, this is what I think. Okay, this is what I mean. Okay, let's see my A&P. Pain in the left shoulder. That's my assessment. Easy, right? Really straightforward. Pain in the left shoulder. I don't put in like, okay, shoulder impingement, shoulder tear or something like that. I don't do that because I don't know. I don't have any imaging. I don't have anything else to determine, okay, if this is a pain on the left shoulder. Okay, but I put in from history and physical exam, this is most likely the acute process. Near tests and Hawking-Kennedy tests suggest a rotator cuff tendinopathy. So I put in what I think is happening to the patient from the physical exam. Okay, I did this test. It's suggesting that, okay, patient may have a rotator cuff issues. Tendinopathy is a pathology with the tendon or something like that. Okay, I just put my thought in. It's definitely okay to put your thought in the assessment, okay? So what do you think is happening? You put it down. So when the next physician see the patient and they read your note, they know what you're thinking about, okay? It is very important to put what you think about. You just don't put, okay, my differential is blah, 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 and this is what I do. You have to put, how did you get to your differential? So it's like your thought process. I want to see that. It's important, okay? You know what near test is? You know what Hawking-Kennedy test is? It's a special test for the shoulder. You should all Google that because it's very good shoulder exam that you can use, okay? I also do one recommendation that if you want a really good shoulder exam or shoulder algorithm, go to the AAFP website. or you can Google AAFP shoulder exam.
Sorry, but I don't hear your sound.
Wait, I've been muting all the time. Oh, I just recently muted. Did you guys hear me what I say earlier? Okay, I may as well repeat it because I don't know when did I mute myself. For some reason, it just mute. That's weird. So yeah, in this section, I want you to put in your assessment, and your assessment doesn't have to be a diagnosis. It can just be pain in the left shoulder. There's a ICD code for that. Okay, and then you put in your thought process. Yeah, you put in your thought process. Okay, this is what I think. This is my physical exam reviews. Okay, blah blah blah. And then I think this may be just an acute process happened with the rotator cuff tendon. Done. And then you review more. My differentials including supraspinatus impingement versus adhesive capsulitis versus AC joint sprains. So it could be a lot of things, but at least you should have 3 differential on there. And then your plan, what you do for patient. Okay, for this patient, I recommend patient rest, put some ice on it, and NSAID for pain as needed. If the pain is not improving in 6 weeks, then I'll consider doing imaging of the shoulder. Could be ultrasound, could be MRI, whatever you choose. If it's me, I'll do an MRI after 6 weeks. And then you follow up after 6 weeks. This is plain for just the shoulder. Any question on this? Very straightforward, right? You put in your assessment, you put in your thought process, you put in your differential, and then what you do for the patient. Now for diabetes, continue current metformin since he's doing well on it. I won't change any medications. Continue to recommend exercise and healthy diet. That's the best thing you can do to control your sugar. And then we repeat some labs today. There's basic lab that I do to all my diabetes patients. I do the basic metabolic panel because I want to see if their electrolytes are doing okay, if their kidneys are doing fine. And I do the lipid panels to see if there's, because he has a history of high cholesterol. So I do a lipid panel. And also do microalbumin and creatine because I want to see if there's any protein in the urine, or if there's any protein leaking out in the blood to make sure that we manage his diabetes and kidney doing okay. All right, that's my plan for him for type 2 diabetes. And then I follow up in 3 months for another A1C check. And then for type 2 diabetes. Any questions? This is a very simple diabetes.
Yes, I have a question.
Yes.
Mr. Leo, can I ask you a question about the diagnosis?
Yes.
In Vietnam, we usually have the common form of diagnosis when we make the medical record or a medical note like that. So in the United States, is there any common form for diagnosis? I mean, the order in the diagnosis. For example, type 2 diabetes mellitus without complications, blah 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 blah, like that. In the order.
We follow the ICD code. So we usually type in type 2 diabetes in the ICD code, and then they give us a bunches of things, and then we just pick the one that most appropriate to the patient. Okay, so in this case, my patient doesn't have any complication, then I just use ICD code E11.9, which is type 2 diabetes without complication. There is another code for if the patient have eyes problem with diabetes, then it will be type 2 diabetes mellitus with retinopathy or something like that. And then there's another one, type 2 diabetes without complication, without long-term current use of insulin, stuff like that. There's a tons of type 2 diabetes. But the order doesn't matter. But you always list your most concerning assessment first. So like if the patient come in with shoulder pain, you list the shoulder pain assessment first. And then this is type 2 diabetes just because I'm his primary care physician. I manage his diabetes as well. So I just put in type 2 diabetes because we talk about it. Okay. Whatever you talk about during the visit, you have to have an assessment for it. Something like that. Sometimes the assessment can just be type 2 diabetes. That's okay too. There's an ICD code for that. You'll be surprised of how many ICD code they have in that ICD code apps. In my electrical medical record, we have the ICD code finder for us, so we can just put in words, like a few words, and then they have like tons, and we just pick. Yeah, the other day I saw something like duck bites also in there, but like whoever got duck bites, so who got duck bites nowadays? Duck don't bite you, okay? But there's an ICD code for that. So yeah, for in USA we use ICD code for everything because we bill for it. By the way, Z code start with Z. Usually preventive care things like encounter for preventive care. They can't bill for it. So usually we address one complaint with the patient and then we put in the encounter for like preventive care because you cannot bill Z code. You will get no money from insurance if you just send in the Z code. And you know what I'm talking about when you start using ICD more and more, because the Z code it's just a preventive care thing. Like vaccination is Z code, well child visit is Z code, stuff like that. Yeah, you just have to do with a lot with ICD. I think Vietnam start to implementing ICD as well. You don't have to memorize this; it's all on the app. You can track this like 10,000 of Z code, like ICD code. So, yeah, that's all the assessment and plan, guys. Any other question on this?
I just want to tell that in Vietnam, in the environment of hospital, physician can use ICD code for diagnosis. But when the student do their medical record for education purpose, we can't use the ICD code for diagnosis. And if the student in my university, if the student do that, he may got 0 for that
really?
subject. Yeah.
For my medical student as well. Yeah, I don't want them to use any ICD code. I have a medical student right now that I'm teaching.
I think it's
yeah, and I just tell them, tell me what you think, and then just write what you think. So yeah, if you have a diagnosis, just write what you think. But for physician in practice, yeah, we use ICD code. So that's why it's so different when you go from medical student to become a physician, because like you're so used to writing your diagnosis down, and then when you're practicing, like I can't write my diagnosis down because I'm not sure. If I write my diagnosis down and I have to treat for it, I mean, I still treat the patient shoulder pain, but I'm not sure what I'm treating yet. So I start conservatively by giving like ice, NSAID, stuff like that. Continue to take your ibuprofens. For practicing physician, use ICD code. For medical students, don't use ICD code. Just put down your diagnosis and why you think it is. Okay. You will never be marked up if you have the proper assessment, even if your diagnosis is wrong. Okay, as long as you justify why you think it is that diagnosis, I think it's okay. I don't know about your teacher, but I give my medical student full points if they can tell me why do they think it is. So my medical student probably like, okay, patient may have supraspinated impingement, and then they will write down, okay, because the shoulder exam is positive, blah blah blah. That's why I think. And their plan is perfect. Their plan is okay, yeah, NSAID for pain and imaging if it's not getting better. Yeah, very simple, right? And of course, I don't let my medical student manage diabetes because it's complicated. Don't let them do that. If you're a teacher, you can teach them about it, but don't let them manage it. They don't know what they're managing. This is my reference I use for today. It's most up-to-date reference for the subnote. So we always bring it to you up-to-date stuff. And thank you for this time, and have any questions, please let me know. I'll stop sharing now for question. Oh, we right on time. I think sorry, I kind of take a little bit more time, but I think I hit all the point I need to hit.
You guys, and you have any question? Can ask him.
All right, no question. You guys are free to go. And I hope you guys enjoy it, and we'll see you in the third case talk. That's the real one. Enjoy your night. Okay? Thank you for sharing.
Do you want to take any picture?
Yes. But before that, I wanna inform you guys. Next week weekends we have to start the real case. Means like we need to practice the like how to take the medical history based on those questions I give you guys the last lesson. Also today you understand well about the short note from the lecture of the Dr. Nguyen. So I hope next week you can revise it and practice a little bit, and we need to come to a real case and collect the medical history, and you also have to work with the SB. Can you get that? Well, about like yes. So please spend time to take a look at those questions, and also how to you take the medical history, and prepare for the next week. So thank you so much for Dr. Leong today. So before we finish our K talk, we need to take a picture. So you guys, please open your camera and then try to smile. And okay, so anyone more? Kalin or Long?
Everybody looks so wrecked today. Everybody's so pretty and beautiful and so bright. All right. Lind, Mr. Nitra. Is that how you say your name?
Yeah, Nitra.
Yes, Nitra.
Nitra. Yeah, Nitra. All right, you guys. Let's smile and okay. 1, 2, 3. Sorry. 1 second. Sorry, Lynn. You sent a message. So this in the picture. They have your message. I'm sorry for that. Just again, please. Okay. 1, 2, 3. Okay. Thank you so much.
Thank you, everybody, and I'll see you in 2 weeks on my case.
Yes, we will meet Dr. Leong in the next 2 weeks. Thank you so much, Dr. Leong, for your lecture today. That's really interesting. And good night, everyone.
Glad you like it. Good night, everybody.
Good night.
And feel free to text me anything if you have questions, okay?
So you guys can leave the Zoom. Yep. Bye bye. See you. Enjoy your weekend.